my session to now having two videos. First is intraocular foreign body removal. Welcome again in Arbil. This patient has a trauma, penetrating trauma by a bullet, not bullet. He was a worker, and he was working with his hammer, hitting a wall. So he was feeling that there is something hit his eyes, but he neglected this his case. He came to me after 1 week. He said, I can't see anything. And of course, we did ultrasound for him. He was full of blood. The vitreous was hemorrhagic. After doing our vitrectomy, finishing our job about the blood, doing core and shave, we tackled with the removal of the foreign body. In this case, it is very important to know the size of the foreign body that you want to remove. And these have many ways. Even if you have a phakic case, you can remove it from the anterior chamber, but in this case, the patient was phakic, and there was no cataract, so we managed to remove the foreign body through one of the ports of the inserted trocars by extending it in a L-shaped extension, by extending them by the NVR. This instrument is a basket instrument. We can tackle it and we can handle it, this foreign body, and draw it out by this way that you see. After removing the foreign body, we close our wound, but our work is not finished yet, because we have to remove all the vitreous tackled in this area. The area is traumatic. The area can't push retinal pigment epithelium inside the vitreous. There is a possibility of PVR, so we have to finish this job properly. Wait and be patient, and take your time in these cases, because these cases can develop to PVR and complicated condition. So we remove all the vitreous over the macula. We have to do ILM peeling. We have sometimes to cauterize the site of the penetration till the sclera to minimize the expulsion of the RPE pigments. So in this case, we are changing to air, and at the end of the day, we do silicone oil injection, and we finish this case properly like this. We can change to the second video. The aim in presenting this video is you have to save the nucleus if there is no cataract. So it's not always that you have to do clear lens extraction. Even in these cases, traumatic cases, foreign body. So if you can preserve the lens, especially if the patient is young. The second video is a case of macular hole and SF6 injection. This patient was 55 years old with macular hole, sudden decrease in vision. The patient was seeing 6:36 suddenly. The importance in these cases that the patient notices the condition, because most of the time when the other eye is good, they cannot notice the blurred vision in the defected eye. So they came to you late, and the macular hole is old, large, ischemic. The surgery will not be of benefit. But in my case, the patient was noticed incidentally that the eye is decreased in vision, blurred. So when he came, we noticed that he has macular hole. Macular hole surgery is a very simple surgery, but it is meticulous. You have to deal with the ILM very cautiously, because you want to remove the extensions and the extractions that present on the macula. So you have to remove the macula. In our new techniques that we do is the inverted flap. The important notice here in this surgery is to dry very good on the macula and the hole. So the flap is to be fixed on the macula and closing the hole like this. Now we are shifting, we did the ILM, we did the flap, and we now shifting to air. When you shift to the air, the trick here is your valves should be new, not causing any turbulence of the fluid or the air, because sometimes when there is turbulence, the flap that you inverted may be distracted. And also, we can use silicone-tipped flute needle to be more meticulous in drying the area. The more you dry, the more the flap will be fixed in his place. Like this way, we have to take our time, we have to be patient. This surgery is not a hurry surgery, so you have to take your time in drying the area to make the flap stable. Still we are drying the area and fixing the flap over the hole. After that, when you be sure that the flap is fixed and dry, you can go out and close your ports by 7-0 Becquerel. Then you go to put the gas inside the eye. We have many ways for injecting gas to the eye. My preferred technique is to use 2 injections. First, to push the gas. The second one to go to make a space, a hole that the air come out. This is, I think, it's more controllable. It's more fast. This is the pre-op OCT, and this is 5th day post-op surgery, post-op result of OCT. The patient was seeing 6:36. After 5 days, the vision improved to 6:18. Thank you very much.
Thank you, Dr. Zana.